Hi, and welcome to the July 2026 DermSurgery Digest podcast. I am the podcast editor, Naomi Lawrence, Cooper Hospital, Rowan University. In this month's Rapid Pearls segment focused on Mohs, cancer, and reconstruction, we have Kyle Lauck doing the article summaries and Ally-Khan Somani providing clinical application and tips. Please don't forget that we continue to offer Beyond the Digest, a podcast covering articles focused on dermatologic surgery but outside of the Dermatologic Surgery Journal, and At the Microscope, a quarterly publication that is topic-focused on histopathologic content relevant to dermatologic surgery. Thank you for listening and have a happy surgery day.
Hi there, welcome to the DermSurgery Digest Rapid Pearls episode. My name's Kyle Lauck, and I'm the current Mohs Fellow at Cooper Hospital, Rowan University. This month's featured expert is Dr. Ally-Khan Somani, MD, PhD. Dr. Somani, thank you again for joining us. Would you mind introducing yourself to the audience?
Yes, thank you, Kyle, for this opportunity to be on your podcast. So I'm Dr. Ally-Khan Somani. I'm the former founder and former director of the MSDO Fellowship at Indiana University. I'm now in private practice and still involved in academics as an adjunct professor of head and neck surgery and dermatology at IU. And I also now teach Cook County residents as their Mohs surgeon. So I'm really glad to be here.
Wonderful. In this episode, we are going to move through the remaining articles from the July 2026 issue of Dermatologic Surgery outside of our Spotlight episode related to dermatologic oncology and surgery. In this Rapid Pearls episode, I'm going to give a brief summary of each article, and then we will hear one or two clinical pearls from Dr. Somani. So we are going to begin with our first Rapid Pearl, where we discuss Digital Papillary Carcinoma, a literature review of epidemiology, management strategies, and patient outcomes by William Liu, first author, and David Talati as senior author. Digital papillary carcinoma is a rare sweat gland malignancy, most often arising on a finger or toe, with meaningful risks of recurrence and metastasis. In this literature review, the author searched Medline and Embase and included 155 cases from 81 articles. Most patients were men, the mean age was 52, and the upper extremity, particularly the third finger, was the most commonly affected. Recurrence occurred in 28% after excision, 29% after amputation, and in none of the three evaluable Mohs cases was there a recurrence. However, 21% of cases with available data did metastasize. The authors conclude that Mohs is promising, but supported by very limited data at this time, and that larger collaborative studies are needed to guide management. So, Dr. Somani, what did you think about this article?
This is an interesting article. I'm glad someone looked at this. So with regards to pearls that I have from reading this article, I have two actually. One is, don't reach reflexively for amputation. As you saw in the paper, the excision versus amputation rates were identical pretty much. I think it was 28 to 29% versus 29%. So that when you're discussing this issue with a patient who has one of these digital papillary carcinoma, the conversation should be towards digit preserving options, and that's where Mohs comes in. So even though the N equals 3 in this study, we all know that any tumor, if you can remove the tumor completely with good confirmation, Mohs has the greatest chance for doing that. So that's one pearl. And the second one is that if you looked at the metastasis rate in these patients, 21% rate, that's nothing to sneeze about. So these patients, for the aggressive ones, need real staging. And I think the paper said that most of the metastasis is within the lung, so imaging, chest x-rays. So you don't want to just walk away from a tumor like this. I think it's important to maybe, do a good lymph node exam and look at the metastatic sites, as well as maybe refer them if there's any concern that this may be one of these aggressive types of, papillary carcinoma.
Yeah, following these people and making sure that they are getting the correct imaging. I feel like, that is really important. Okay. Moving to our next article is Surgical Interventions for the Treatment of Hidradenitis Suppurativa, a systematic review of surgical impact on DLQI, with Sarah Moffat as first author and Brielle Weinstein as senior author. Hidradenitis suppurativa can severely impair quality of life in advanced disease, often requires surgical management. This PRISMA-guided systematic review examined 8 studies with 262 patients using the Dermatology Life Quality Index as the primary outcome. Across varied procedures, surgery generally improved quality of life. Wide local excision was relatively efficient but could require prolonged wound care and carried recurrence risk. Skin grafting did not show a clear advantage, while photodynamic therapy after excision was promising but resource intensive. For axillary disease, perforator or muscle-sparing flaps appeared to offer smoother recovery and low recurrence. The authors conclude that surgery can be beneficial, but procedure selection should remain individualized. Now, this article kind of moves outside of our traditional Mohs context, and so I'm curious what experience you have with the Somani or Dr. Somani, what you thought about this article.
Yeah, so again, I agree with you. This kind of falls out of our expertise, but I know I have many Mohs surgeons, academic ones, who do take care of patients with hidradenitis suppurativa. Um, uh, a lot of it is just marsupialization and re-excising them and allowing them to scar down. I think that the article, I think the main point here, and I don't know, I wouldn't really be putting a graft on these. It's a difficult site to, first of all, so 40% failure to me wasn't a surprise. One thing that was important is if you're going to repair these, I think the vascularized flaps make sense. So either the ones that were mentioned in the paper, but also these patients have their journey is pretty, even if they're healing by secondary intention, that's 4 months of daily wound care. So you really got to set them up right so that they know what to anticipate. The other thing also is we're not really treating the underlying cause. And I think now with the biologics and recognizing this as an inflammatory disease, I think there's a lot of new therapies, systemic therapies that are being explored. And I think that if I had a patient who was diagnosed with this, and I've had them, I probably would refer them back to dermatology to see if there is a more systemic treatment option available to them to get the disease under control.
Yeah, I think that is a great plan. There are many components to this disease, and I think we
Mhm.
play a role in some of them, but they do need somebody to guide their medical therapy.
As a DermSurgery Digest listener, here is some quick partner information. Mark your calendars out of office this November 5th through 8th. Learn why from our 2026 ASDS Annual Meeting Workgroup Chair.
Hi, I'm Nazanin Sadie, and I wanted to encourage you all to attend the ASDS annual meeting in San Diego this November. It's going to include all of the hottest topics in dermatologic surgery, spanning from cosmetic dermatology to Mohs surgery to reconstruction. We're going to have interesting topics like the latest in GLP-1, wellness, menopause, regenerative medicine, and from experts from around the world. I hope to see you all in San Diego.
To learn more and register today, visit asds.net/annual meeting. The future of dermatologic surgery starts here. And now, let's get back to the conversation.
So, moving on to our next article, we have an experimental model to assess the tensions at margins of incisions with varying formats and lengths by primary author Victor Enrique Murbach-Dori as first author and Anna Carolina Miola as senior author. High wound edge tension can worsen scarring and dehiscence, but the mechanical effect of incision geometry has not been well studied to date. In this laboratory model, the authors created straight L-shaped and S-shaped incisions measuring 1 to 5 centimeters in latex bands intended to simulate skin. Each model underwent standardized 1 kilogram traction, and edge separation was measured using image J as a proxy for tension. Smaller incisions behaved similarly, but beyond 2.5 centimeters in length, straight incisions showed greater tension than angled designs, with S-shaped incisions performing best. The authors conclude that the incision shape may redistribute force while emphasizing that validation in human skin is still needed. I find these studies interesting because I don't know how well they translate to human skin, but I'm curious what you thought about it, Dr.
Yeah,
Somani.
so I actually was very critical of this paper, and I can raise some of my issues. But one of the things is this is a latex model; it's not human skin. Number one, it's isotropic, not anisotropic like human skin, which can basically, it's mobile, it's biologically active. It can basically accommodate, you've got collagen, mechanical creep, for example, happens even with stretching. So there's a lot of reorientation. But if you look at the other flaps that they cut on this latex, if you look at the way the tension is lateral and the cut is perpendicular to the tension. We never close things like that in real life. And in fact, if they just made that linear incision along the tension line, then the sutures would be in the what do we call it? The lines of maximum extensibility, which is what we do. So then the line would be not so gapping. And that's why if you look at the L-shaped and you look at the S-shaped in their paper, it's always the orientation of the ends, the arms that are parallel to the tension lines are the one that have the least gapping between them. So I think that the model does not fit reality in my opinion.
Yeah, in vivo versus ex vivo, it is. Yeah, it's very good points. So,
Yeah, and I think a study like this should probably be done on maybe fresh cadaveric skin,
yeah, yeah,
something that's much more able to simulate or be, in kind of in vivo, but ex vivo, obviously in a cadaveric, but allow us to look at the dynamics on different parts of the tissue. So um, I don't think that this will change anything that I do clinically because their stress force was not aligned correctly, in my opinion.
yeah, good points.
So.
All right, moving on to our next article, uh, a case report that we're going to discuss, a rare presentation of recurrent aggressive proliferating pilar tumor mimicking squamous cell carcinoma, diagnostic and therapeutic challenges, with Ria Patel as first author and Aaron Joseph as senior author. Proliferating pilar tumors are uncommon scalp tumors that may clinically resemble squamous cell carcinoma. The authors describe a 31-year-old woman whose presumed pilar cyst was excised and then rapidly recurred 9 months later as a large keratotic scalp nodule. Repeat sampling showed persistent proliferating pilar tumor, and the lesion was treated using frozen section margin control. Histology demonstrated trichoeliminal keratinization without malignant cytologic atypia, supporting a benign but locally aggressive tumor. The wound healed without complication, and the authors conclude that proliferating pilar tumor should remain in the differential for rapidly growing scalp nodules because aggressive clinical behavior may occur despite the relatively bland histology. Dr. Somani, I'm curious what you thought about this article.
Yeah, I kind of agree with that. I think when clinical behavior outpaces the histology, I think rapid growth, recurrence, exophytic mass, treat the behavior, not just the slide type of thing. Like the histology may still seem like it's fine. Interestingly enough, I've even seen KAs that have been biopsied, which recur really rapidly. And at least from my perspective, these tend to be the more aggressive type of squames and KA type. So I think that sending a debulk is also important. If you see something that looks aggressive, send for permanent pathology. Um, and I really feel that young patient, rapidly growing, uh, you need to make sure that it's not one of these aggressive, proliferating pilar tumors that are mimicking SCC. Um, and because it overlaps, the diagnosis overlaps with the keratoacanthoma type SCC as well. So,
Yeah, that's a
um,
good point.
yeah.
Okay. All right, moving on to our final article here. So, for our last rapid pearl, we are going to discuss a reduced epinephrine efficacy and increased bleeding risk in rosacea during central facial surgery by Vijay Kodamudi as first author and Carl Schonbacher as senior author. Rosacea causes persistent facial vasodilation, but its impact on surgical hemostasis remains uncertain. In this retrospective cohort study, the authors evaluated 509 patients undergoing Mohs surgery and same-day central facial reconstruction. 146 had erythematotelangiectatic rosacea. Blood loss was estimated by gauze weight, and epinephrine response was assessed by clinical blanching. Patients with rosacea had greater blood loss during both Mohs surgery and reconstruction. Epinephrine produced blanching in only 50.1% of rosacea patients versus 98.9% of controls and did not significantly reduce bleeding within the rosacea group. The authors conclude that surgeons should anticipate reduced epinephrine responsiveness and emphasize timing, appropriate dosing, and mechanical hemostasis when it comes to these patients that have rosacea. So interesting study on a specific group of patients. I'm wondering what you thought about this, Dr. Somani.
Yeah, I thought it was really a good study because this matches what we see clinically. I've had all the patients that ooze have this erythrometalangentatic rosacea where they just they ooze, and even with epi. One thing I found interesting is that normally when I inject patients, I'm not looking for blanching as much as I'm looking for lack of pain once I check to see that they're completely numb. So I know that when you add a lot more, obviously you're adding a lot more, but the end point is really also pain. So that was one thing, and most of our patients also are on anticoagulants too. So it'd been interesting to see if they had done this study with some patients and done a subgroup analysis to see what happens with if you're on an anticoagulant. Is it synergistic? Is the time? Do they bleed even more? Does it take longer? But one good thing about these patients, if you recognize this, and I think the paper mentioned this, is waiting the 26 minutes or 25 minutes or whatever it is that allows us to maximize on the vasoconstriction. But most of the rosacea is in the postcapillary venules. And the hypothesis is that it's alpha adrenergic receptors are not responsive, but those are pre-sphincter. So it's kind of a mixed bag, and you have the inflammation, you have all that. The other thing that has changed my practice is the use of tranexamic acid. And we always put that into patients that are on blood thinners and also on areas that we know are going to bleed a lot. And I think it's been a game changer for me, at least. It has really definitely reduced the amount of bleeding I see in my patients.
We recently introduced TXA into our protocol here, and game changer is absolutely the word that I would use. I think that it is great for these patients. I mean, honestly, I will start thinking about these rosacea patients a little more now, and
Hmm.
like it's trying to anticipate it with TXA. But you're right,
Yeah.
it's a game changer. So, all right, and that was a really interesting point about the alpha adrenergic. I did not, man, we are going back to medical school with that physiology right there. Thank you. So, I think this is a good place to close out. Dr. Somani, thank you again for sharing all of these pearls and your practical perspective. I really appreciate you taking the time to come on the
Thank you. It
podcast.
was my pleasure, and good luck. I know you're finishing your training, so good luck with all of your final training.
Thank you.
And it was my pleasure.
Thank you. And this concludes this edition of DermSurgery Digest. Thank you to all our listeners for joining us. And please visit asds.net/DermSurgery Digest for additional journal podcast content, and have a great surgery day.
Thank you for listening to DermSurgery Digest, the official podcast of the Dermatologic Surgery Journal. To access these featured articles, author videos, and much more, visit journals.lww.com/dermatologic surgery. To learn more about the American Society for Dermatologic Surgery, visit asds.net.